I'll I'll be starting with the meeting today. So basically, this is my outline that how I'll go about. So today, first, I was given this by Dr. Palestico's PPT I have. So I'll be taking up the regulation of the body fluid starting with the revision of it. Then I'll be going with the anat and the physio of the basic urinary tract and the second chapter today. And the next chapter, I'll be talking about all the channels and the mechanism, and then the remaining topics in the system. So first, I'll be going with this PPT. So one second. Guys, you can switch on the videos. It feels awkward. So first, what is the function of all the body fluids? So basically, the function of the body fluids is to transport the nutrients, the hormones, the proteins, and other molecules into the cell, to excrete all the waste products from the body, to maintain the cellular metabolism in the body, to regulate the body temperature, then to lubricate our muscular skeletal joints, and to be an important component of all the body fluids, body cavities. So basically, I have just made this thing. So in infants, it's around 75% of the body weight is your fluids. And then in males, you can say it's approximately an adult male of around 70 kgs. You can approximately say it's around 60%. In females, it's around 50% because in females, the fat mass is more and the muscle mass is less. And then for males, you can say that this is the water content, that is 60% of the body fluid. It's divided into two things, the intracellular fluid and the extracellular fluid. The intracellular fluid being the 2/3 of the total body weight, total water weight of the body, and the ECF being the 1/3. Now, what is the intracellular fluid? So intracellular fluid is everything that's obviously inside the cell. It's 2/3. So you can say it's around 28 liters for a 70 kg person, which is 60 kg. The total water weight is 42 liters, and ICF can be told as 28 liters. The ECF is 14 liters because it's 1/3 of the total weight of the water. Now, wait, sorry. The ECF is subdivided into interstitial fluid and the plasma fluid, the blood plasma. The interstitial fluid is the fluid that is found in between the cells. Now, this interstitial fluid is 3/4 of the total water, this thing. And of the ECF, it's 3/4, which says it's around 11 liters. And for the plasma, it's 3 liters because it's 1/4. Now, this we can say. Now, going back to this. So what is this depended on? So this is depended on the tissue type, the gender, the age. Now, basically, in males, they have more muscle, so their body fluid content is also more. Then if you do more exercise, then your output would be more, because via sweat, via the urine output and all, this accounts to more of the output in a person who exercises regularly. So tissue, your gender, your whatever you work out, these things are very important and have to be considered. This we saw right now. So what is this blood volume consisted of? So it's plasma and the formed elements. These formed elements are very important because these are the elements which will lead to your oncotic pressures. So this is your red blood cell, your white blood cell, your platelets and everything. And your plasma is found in the ECF. It's rich in proteins, and 60% of the blood volume is your plasma, and rest everything is the everything that comes in your CBC. You can just remember it like that. So When you do the centrifuge method, this is not that important, but you can just remember that RBC is usually at the bottom of it because of its size, and on the top is the plasma because it's light weighted. I'm just revising this fast so that we can go about by the kidney after the fluids we know. So what are the contents? What are the contents of the fluids? So basically everything, all the cations and the anions are there. We'll be looking on to these things in the whole urinary system, that what is the size of it and how is it filtered out of the Bowman's capsule and everything. So we'll be just going through it. So yeah, in this, I find that these things are to be noted and it's very important. Now we'll be starting with the main discussion. So yeah, so I'll be continuing. So firstly, I'll be talking about the histology of the urinary system. So the urinary system, it starts from your urinary bud, and then which gives rise to the urinary system. Um, so basically, there is the surrounding loose mesenchyme, which is the first step that arises from your urinary bud, and then this mesenchyme is condensed eventually, leading to an S-shaped formation, which will form a hollow, and this S-shaped formation will take place to form your kidneys and all the system. Eventually, there will be tubule elongation and the podocyte folding. So this is important steps that you need to remember. So first, after the uteric bud, there is loose mesenchyme that comes into the picture. Then there is condensation. Then there is S-shape formation. There is this hollow formation. Then the tubule elongation, and then the podocyte folding. So this is what I explained, that thinning of the epithelium on one circumference of the blind end of the S-shaped tubules lead to the emergence to the future parietal layer of the Bowman's capsule. So the future parietal layer forms via these S-shape. Parietal is the outside layer. This you can see it forms this thing. This thing is formed by the S-shape. And then in contrast, the opposite visceral layer thickens and attaches to the glomerular capillaries. These visceral epithelial cells then fold and develop into podocytes, which is an important component in the filtration unit. Then these podocytes, modified epithelial cells, thus represent the visceral layer, and so is the formation of your renal corpuscle. So each kidney consists of around 8 lakh to 12 lakh nephrons. And then a nephron consists of a glomerulus and a tubule. The glomerulus is a cluster of blood vessels from which the plasma filtrate originates. The tubule is an epithelial structure consisting of many subdivisions. So these are designed to convert the filtrate into the urine. These have two entities, that's the vascular and the epithelial. So the epithelial is the one that meets with the tubule epithelium at the end and forms the Bowman's capsule. So basically, it's just consisting of the vascular system, that's the glomerulus at the top, then starts your tubular system via the Bowman's capsule. So it is here that the filtrate passes from the vascular system into the tubule system. The epithelial elements of the nephrons, including the Bowman's capsule, the proximal tubule, the thin descending limb, the thin and the thick ascending limb and the thin descending limb of the loop of Henle, the distal convoluted tubule and the connecting tubule. The connecting tubule leads further into the initial collecting tubule, the cortical and the medullary. So this I'll be showing in this way. So this is your PCT after your Bowman's capsule. Your PCT is also divided into 3 parts. Now these 3 parts are S1, S2 and S3. We will be talking about it later. So this is your PCT. It goes down, it forms your proximal straight tubule. This is usually known as the S3 component. So now after that, this is your loop of Henle, your DCT, your initial collecting tubule, then then this starts your whole collecting duct. So basically, the superficial nephrons are the ones which are 90%, and the juxtamedullary nephrons are only around 10%. Superficial nephrons have short loops that extend to the boundary between the outer and the inner medulla. See, this is the outer and the inner medulla. So these short loops, this can be known as the superficial nephron. These are your juxtaglomerular nephrons because it's in between the junction between the cortex and the medulla. This is your juxtamedullary nephron, so it has a very big loop of Henle. So the renal corpuscle has three components. It's the vascular elements, the mesangium, and the Bowman's capsule, and the Bowman's space. So I'll be now talking about the arterial system of the kidney. So first, the arterial system starts from the abdominal aorta. It gives rise to your renal artery that inserts into the kidney via your hilum. Now this renal artery, this is your renal medulla, the striated portion. This is your renal cortex, the granulated portion because of all the Bowman's capsule and everything situated into it. Now these striation, this this is known as one lobe, this one medulla. So this artery, renal artery, then flows into the interlobular artery. It joins this interlobular artery. Then it forms the arcuate artery. Then it forms the arcuate artery over here. Arcuate artery, just like, see, these arcuate arteries are there in the body, a lot of places you will find where it forms an arch like this, and it's usually known as the arcuate artery, like in your hands, your foot also, you will study this. So this arcuate artery then extends into the cortex as these are known as the corticoradial artery. They are in the radial fashion and it's known as corticoradial. So it's very easy, the renal artery into the interlobular space as interlobar artery, then the arcuate artery and the corticoradial artery. Now this corticoradial artery, it is the one that forms your afferent arteriole. Afferent arteriole joins the glomerulus and then to your efferent arteriole. See, this you can say, this we studied, this is your interlobar artery, this is the arcuate artery, then this is your corticoradial artery, I'm so sorry. This is your corticoradial artery. Now this corticoradial artery gives branches. This is your afferent arteriole, this is your glomerulus, and then it joins the efferent arteriole. Here also, this is your afferent arteriole. Now we will study why this afferent arteriole is so deep and this afferent arteriole is over here only. We'll study that later. First, let's revise the whole. Can I just tell someone that please stop writing on the screen if someone is writing? I don't know who is doing this. Yeah. So we studied till here that the efferent arterioles. Now, what does this efferent arteriole do is it forms the peritubular capillaries. So this peritubular capillaries then forms the venous system. So after the peritubular capillaries, it gives rise to these corticoradial arteries. Then these corticoradial veins. Over here is your first, this corticoradial artery joins your afferent arteriole, then your glomerulus, then your efferent arteriole. Efferent arteriole joins your peritubular capillaries. Peritubular capillaries then join your corticoradial vein, which eventually joins your arcuate vein, which eventually joins your interlobar vein, which eventually joins your renal vein, and it exits out of the kidney. So this is the whole artery and the venous system of the kidney. Now moving on to the basic anatomy. So this is your ureter, this is your renal pelvis. Basically all these renal medulla, they converge in the center to form your renal papilla. It's like here where the urine is collected before passing on to these minor calyces. These are the minor calyces that it flows into. Then 2 or 3 minor calyces they form together the major calyx. The major calyx then forms this structure over here that is known as the renal pelvis, and then it exits out of the ureter. So you can always remember that the urine, this will be very important for studying the clearance, the renal clearance. So for that, the entry point is just one of the artery. The exit point of the blood, or you can say the fluid from the kidney, is two. It's via the renal vein and the ureter. Also, these are known as the renal columns, which are the extensions of the cortex in between the medulla. So, Kshitish, can you tell someone, whoever is writing, not to write? I don't know who is doing this. Hello, Kshitish? 90% of
Yes, yes,
yeah,
yes, I'll tell them.
yeah, please. 90% of the blood that's entering the kidney perfuses via the superficial glomeruli and the cortex. Only 10% perfuses via the juxtamedullary glomeruli. We studied this, that these very nearby to it are the very nearby to the medulla, in between the junction, is known as the juxtamedullary apparatus. So these juxtamedullary nephrons, they just drain around 10%, and the cortical nephrons will drain around 90% of all the fluid that's entering. And also one more thing is important, that the collecting duct, it um, it joins the renal papilla. We studied the renal papilla is convergence of the renal medulla. It joins it via the papillary duct. Now going on to the lymphatic system. So the lymph system is also very necessary. It's usually, it drains the interstitial fluid of the cortex, and it may contain high concentrations of the renal hormones, that is your erythropoietin. Your erythropoietin is usually secreted by the fibroblast. We'll be coming to it later. It leaves the kidney by following the arteries towards the hilus. So all the artery channels, it comes via your celiac plexus. The lymphatics are absent in the renal medulla. Via the cortex, it goes by the celiac plexus, following all the arterial routes, but it's absent in the renal medulla, where there would be otherwise, because we have to maintain all the high osmolarity interstitial fluid for proper absorption of all the nutrients, and therefore there is no lymphatics present in the renal medulla. Now, this is your renal corpuscle. What is your renal corpuscle? It's basically the glomerulus and the Bowman's capsule in all. So this I just made. So these, you can say, this is the lining, that is your parietal lining of the Bowman's capsule. These are your podocytes. These foot-like projections are known as your podocytes. This is your afferent arteriole. This is your glomerulus, your efferent arteriole. The afferent arterial diameter is always greater than the efferent arteriole diameter, because it has to concentrate the urine in the middle. So um, these cells have one second here. Usually the capillaries that is in the Bowman space has fenestrations. These fenestrations have, it's around 150 to 100 nanometers, and via these fenestrations, all your electrolytes, your small proteins, your water, and the nutrients can pass through it. And this is the parietal layer that was formed. We studied it earlier, how it was formed. This parietal layer has these slips, which allow for the passage of these nutrients into the basement membrane, via which it will enter your Bowman's capsule. The basement membrane is very important. How is it made? So it's basically, this is your basement membrane. In between, it has type 4 collagen. It is divided into 3 layers. The inside layer, that is in coherence with the parietal layer, in coherence with the visceral layer, I'm so sorry. With the visceral layer is your lamina rara interna. And the one that is towards the side of your podocyte, that is known as rara externa. So in the middle is your type 4 collagen. or it also contains laminins. And these your surrounding layers, that is your lamina rara interna and your lamina rara externa, has heparin sulfate. Sulfate has negative charge. Negative charge. So here you can say there is negative, negative, negative charge on this layer, negative, negative, negative charge on this layer, because of which big proteins, as in albumins and all, everything or any macromolecule that has a negative charge won't pass through this layer. This is very important for the basement layer. It's the glycocalyx component is your heparin sulfate that is present in your basement membrane. Then later on, these are the podocytes. The podocytes are connected via your nephrins. And these podocytes, in between the podocyte, this space is usually, can anyone say what is the space known as? You can chat or you can say hello. Okay, I'll just say it's the filtration slit. This space is known as the filtration slit. It is around 25 to 30 nanometers. It will help you. So basically, first, these fenestrated capillaries have 50 to 100 nanometer. It will filter everything. Then it will pass through the basement membrane, and over here also it will be filtered. Then your nephrin comes. The things that are not filtered via your filtration slit will be filtered via your nephrin, that has 7 to 9 nanometers of the space in between. This whole thing, the nephrins in your filtration slit, is known as your slit diaphragm, which is very important in many of the pathologies. Nephrin, when the function is lost, nephrin and podocin, which is a very important part of your podocyte, then many nephrotic syndromes can also be caused. You will study that later. Now, this thing that I have drawn nearby to your afferent arteriole is your macula densa. Your macula densa, it's very nearby to your afferent arteriole. It senses the pressure difference that is coming into the afferent arteriole. If there is low amount of sodium, or there is low amount of fluid that's entering and less pressure, then the macula densa will be alerted. There are mesenchymal cells which have connection to the macula densa nearby to it, and these mesenchymal cells, they will have the chemoreceptors, and the macula densas will have your baroreceptors, and these are very important in maintaining the all the pressure differences in the body. So this is the basic structure of your podocyte. These are the capillaries that we saw. These are fenestrated capillaries. This is your basement membrane that has 3 layers: lamina interna, lamina externa, and in between your type 4 collagen layer and the laminin layer. Then this is your podocyte, that is of your Bowman's capsule. Now, I'm just illustrating this. This is not that important, but you have to take in account these proteins, the nephrin and the podocin. It will be used in the future a lot. The nephrins and the podocin, that's part of your podocytes effacement. That is, when these podocytes are detached from your basement membrane, then it leads to the leakage of proteins and all into your Bowman space, which can lead to protein urea, lipid urea, and all these things, which are very important pathologies, and you have to take into account. These 2 proteins are very important: podocin and nephrin. So nephrin, neph1, podocin, and other membranes organized on the lipid rafts. Lipid rafts is basically the parietal layer that we talked about of the podocytes. They form the slit diaphragm. Now, this Finnish type of nephrosis. This is a genetic disorder, which is the absence of nephrin. Now, if there is absence of nephrin, then what will it happen? There is no that 7 to 9 nanometer difference in between the podocytes, which leads to a continuous leakage of a lot of nutrients, not just nutrients, macromolecules into your Bowman space. Supporting the glomerular capillary loops in a network of contractile mesenchymal cells which secrete the extracellular matrix. This network is continuous with the smooth muscles of the afferent and the efferent arterioles. The matrix then extends to the extraglomerular mesenchymal cells. The thing that I told you, the mesenchymal cells, which are very important chemoreceptors, um, it connects your afferent arteriole, and eventually the efferent arteriole will also be sensed. The tubule components of the nephrons include the proximal tubule, the loop of Henle, the distal tubule, and the collecting duct. The proximal tubule can be divided into proximal convoluted tubule and the proximal straight tubule. So this is your proximal convoluted tubule and this is your proximal straight tubule. Now, based on the ultrastructure, it's divided into S1, S2, and S3. The S1 segment starts at the glomerulus and includes the first portion of the proximal convoluted tubule. This is your S1 here. Till here, you can say it's your S1. Now the S2 is the second part of the proximal convoluted tubule and continues till the first half of the proximal straight tubule. The S3 includes the distal half of the proximal straight tubule and extends into the medulla. So this is self-explanatory, it extends into the medulla. So this you have to remember how many parts it's divided, the proximal convoluted tubule. Now the apical membrane has foldings. There is two, you can say, you know that there is apical membrane, then there is the basement membrane. So the apical membrane has enfoldings in the form of well-developed brush borders. Why is there brush border appearance of the PCT? Because it has to absorb a lot of nutrients and has to secrete also. So because of this, but the main function is absorption. So for the absorption, we have to say that there is well-developed brush border. The basolateral membranes has of the adjacent proximal tubules form numerous interdigitations. This has a lot of mitochondria also because of its function, and it's in close contact to the plasma membrane. This complexity eventually reduces as you go down into the nephron, because at the starting your absorption is very important, so there is abundant mitochondria, there is abundant interdigitations also seen. From S1 to S3, the cell complexity progressively declines and it leads to gradual decrease of reabsorptive rates along the tubules. Thus, the cell exhibit a progressively less developed brush border appearance, diminished complexity, and also your lower basolateral membrane area and decrease in mitochondria, because the maximum absorption is done in your PCT, maximum work. So this is not important in the later nephron. In comparison with the S3 segment, the cells lining the ascending and the descending limbs are far less complex. The distal convoluted tubule, it begins at the macula densa. The PCT extend to the loop of Henle, and then near the macula densa forms your DCT, and it ends at the transition of the connecting tubule. The connecting tubule, which ends at the transition to the initial collecting tubule, consists of two types. So I'll show you this. So this is your PCT, your loop of Henle, the DCT. See, where does the DCT starts? It starts nearby. Over here is your JGA, that is your juxtaglomerular apparatus. Near that starts your distal convoluted tubule, then is your connecting tubule, then your initial connecting tubule. Then these things are only being noted. If it's in cortex, it's the cortex collecting tubule. If it's in outer medulla, it's the outer medullary, then the inner medullary connecting tubule. So the two segments following the connecting tubule, the initial collecting and the cortical collecting, are identical. They are composed of two cells, which is very important. It's the intercalated and the principal cells. Intercalated cells consist of 1/3 of the lining, and the principal cells consist of 2/3 of the lining. The intercalated cell, they lack a central cilium. It has A cells. Now A, you can just remember it like A for acidity, so that is why it secretes H plus and reabsorbs K plus. Whereas the B cells, or the, you can say, bicarbonate, it secretes bicarbonate anion. Then you can say that the principal cells, they have fewer mitochondria, and They have modestly developed invaginations of the basolateral membrane and a central cilium. Here, there is a central cilium. In intercalated cells, you cannot find a central cilium. The principal cells, they reabsorb your sodium and the chloride, and it secretes the K plus. This is very important. Who does, when this will be important, because all these thiazides in diuretics and all, these things would be your main target, your principal cells, to target your reabsorption of sodium and chloride. So now the juxtaglomerular apparatus is a region which where each thick ascending limb contacts its glomerulus. The tightness of the tubule epithelial increases from this we studied as we go down the nephron. It increases. Sorry, the complexity decreases and the tightness increases. I'm so sorry. Starling forces are the ones that will be very important. Starling forces are your hydrostatic pressure, your oncotic pressure. These forces that these forces are very important, which govern the flow of fluid across the capillary walls in the glomerulus and result in the net filtration. Your thick ascending limb has a very important function. It secretes the TAM, Holzpaul glycoprotein, or also known as your uromodulin. This uromodulin is very important because it acts as an innate defense against all the urinary tract infection. It's very important also because it helps in the reabsorption of sodium chloride and other nutrients. Um, it also forms a protection against your tubular interstitial nephritis. So this thing is very important. You have to always remember that uromodulin is secreted by your thick ascending limb. And in normal subjects, it's around 30 to 50 mgs per day into the urine that you find. And also along with the albumin that you can say around 20 mgs that enters your Hohmann space. Now, uh, talking about the sympathetic nerve fiber, your sympathetic and the parasympathetic system. So the sympathetic system, it regulates the renal blood flow, the glomerular filtration, and the tubule reabsorption. Celiac plexus it initiates from, and it generally flows via the arterial vessels into the kidney. The sympathetic stimulation to the kidney has three major effects. First, the catecholamines, they cause vasoconstriction. Vasoconstriction is very important when your BP is low and you need vasoconstriction. That times your sympathetic nerve fibers play into action. You have to always remember this, that it plays into action for causing the vasoconstriction. Second, the catecholamines, they strongly enhance your sodium reabsorption by your proximal tubule cells. Third, as a result of the dense accumulation of the sympathetic fibers near the granular cells that is in the cortex of the JGA, they increase the sympathetic nerve activity and stimulates your renin secretion. Why is renin secreted is because when there is low BP, we have to increase the BP, then the JGA cells will detect that change in the body that the BP is low, it's entering low into your nephron. So it will initiate the sympathetic nerve activity, which will stimulate your renin. Kidneys act as a very important endocrine organ also. It secretes your vitamin D, erythropoietin, prostaglandins, bradykinin. Now your vitamin D is secreted, is converted into the active form by your PCT cells. Your fibroblast in the interstitium of the cortex and the outer medulla, they secrete your EPO, which is very important when you have to treat severe anemia. Then there is why is there severe anemia? Because there is deficiency of EPO, and then it is secreted mostly in response to the fall of the local tissue oxygen pressure. Now, EPO stimulates the development of red blood cells by action on hematopoietic stem cells in the bone marrow, and in chronic renal failure, as I said, it can be treated via recombinant erythropoietin that we can give to the patient. Prostaglandins and bradykinins are your vasodilators, which are very important vasodilators because they will act on your afferent arterioles in order to increase the blood flow into your kidneys. The kidneys release prostaglandins and several kinins, paracrine agents that control the circulation within the kidney. These substances are vasodilators and may play an important role when your renal blood flow is compromised, because they have to increase the renal blood flow. So your prostaglandins, your nitric oxide, your bradykinin, all of these vasodilators in the body will play an important role. The tubule cells also secrete angiotensin, bradykinin, the cyclic AMP and ATP into the lumen. Together, the three basic functions of the kidney, that's your glomerular filtration, your tubule reabsorption, and your tubule secretion, they all determine your renal clearance of any given solute, say it be sodium or potassium or anything that enters into your kidney. So these are the three important things that will govern how is it regulated. The clearance of a solute is the virtual volume of plasma that would be totally cleared out from your nephron. So basically, this says that clearance is whatever is entering is coming out. They virtually assume this and then they estimate what is the clearance. So for any solute that the kidney does not synthesize, degrade, or accumulate, that means it's not being stored inside the kidney. Whatever will come in will go out. So in that way, we assume the clearance this thing equation, and we can say that the entry point to the kidney is just one, that is your renal artery, and the exit point is two, your renal vein and your ureter. So just assume that put X as the uh, because the input is always equal to the output. This is an assumption that we just take into account for getting to know the clearance. An estimated clearance, it's not always the exact one we can calculate, but we can say that the input is always equal to the output. So input is your arterial input is equal to the two outputs, that is your venous plus your ureter input output. So now we can say that the px arterial, this is your px arterial, that is the pressure in your arteries, then your pressure in your vein, and this is via your ureters. This RPF is always the renal plasma flow in the artery, the renal plasma flow in the vein, and this is the rate of the urine exiting out. So you can say this as V right now. The UX, as it's known as, it's being given as the concentration of X, any given solute in the urine. Suppose we want to calculate sodium, so we can put sodium over here. It's urine output, so we can calculate in such a way. The product, that was this product, the urine output product, is the urinary excretion rate, the amount of excreted in the urine per unit time. In developing the concept of renal clearance, we transform the equation in two ways, both based on the assumption that the kidneys clear all that is entering into the arteries. Now, first we replace the RPF that was given, RPF A, this one, with the inflow of the virtual volume, the clearance of X. So we are just assuming that whatever is exiting, whatever is coming inside is going out. So we just replace this by the clearance of the solute that we have to take into account. Second, we assign the virtual venous output as zero, because we are assuming that it will be all given out via your urine, your artery. So we are just assuming the venous as zero. Now, this describes the classic clearance equation. So this shows that PXA, that is your pressure in the arteries, times your concentration or your clearance of the given solute is equal to your urinary excretion rate. And this we can modify in order to get your clearance of the clearance of the solute. We can modify as saying that it's urinary excretion rate upon your pressure in the arteries. This we can just change by anything, by adding any given substance, or your PAH and the inulin. Now, what is this pH and the inulin? These are very important proteins. Urinary inulins are never being secreted or absorbed in the tubules, nor is it synthesized in the kidney. Therefore, if you inject inulin into the system, so it will be into your afferent or the efferent arteriole. We usually insert it into the afferent arteriole in order to take account of the ideal renal clearance. So whatever will enter is going to exit out. So urinary inulin clearance is considered as the gold standard because it's considered as an ideal marker for the renal clearance. Also, your para-amino hypuric acid is also very important because it's not made in the body, so it can also be used, but secondary to inulin. So this is important. So sorry. Now talking about the GFR, I'm so sorry. So talking about the GFR, it's the volume of the fluid that's filtered into the Bowman's capsule per unit time. Now imagine a solute X that fulfills both the criteria that it's not reabsorbed, not secreted, not made in the kidney. Now we have to calculate that into the GFR. So we will take into account the amount of the X that appears in the urine per unit time. Your urinary excretion rate is the same as the amount of X that the glomerulus filters per unit time. So we can say that the px that we said, this is the cx that we wrote, the clearance of X. We can assume this as the GFR. This is equal to your UXV, that's your urinary excretion rate. Now, the input to the Bowman's capsule is also known as the filtered solute load and is generally given in millimoles or per unit time. So this you can say, as we said.
Yesterday, who is she? Something.
So the input to the Bowman's capsule. So this is your input and the output. This is your urinary excretion rate. So you can modify this always. So the GFR is always your urinary excretion rate upon the pressure of the solute. So this is very important. This is just an illustration that whatever enters is going out. So you just need to have its calculation accordingly. You can modify the formula. You just have to remember this formula and you can make use of it via any given equation to you. The normal GFR in the body is 125 milliliters per minute, and the normal renal plasma flow is around 600 milliliters per minute. If there was no proper maintenance of the filtration slit and everything, then the total whatever blood is coming in can be excreted out of the urine within half an hour if this normal GFR is not maintained via the kidney. A healthy urine output for an adult person is around 0.5 milliliters to per kg per hour. You can also say it's around 800 ml to 2 liters if the person is consuming around 2 liters of water per day. So you can just assume it like that. But if it's given that it's less than 30 ml per hour, then it's a thing that is to be concerned. Now, this is a case. I would just want one volunteer to read this, please. Hello? Shitish, anyone? Yeah, Anisha, please go ahead.
AL is a 41-year-old male who has a long-standing history of hypertension and diabetes and presents with a complaint of pruritus, lethargy, lower extremity edema, nausea, and emesis. He denies any other medical illnesses. On physical exam, the patient is a well-developed, well-nourished male in moderate distress. Blood pressure 180 over 110, pulse 80, respirations 24, and he was afebrile. Body weight 76.5 kg, HEENT was remarkable for fundoscopic findings of AV nicking and copper wire changes consistent with hypertensive injury. Cardiac exam had an
Okay.
S1, S2,
Okay,
and S4.
Anisha.
Yes.
Yeah, just getting to know this, can you just tell me what all do you find, the main pertinent points that can point towards a problem in the body? What all do you think? The main things that you will highlight in a case when you find a case like this?
We can look at the point like a long-standing history of hypertension,
Very good.
diabetes,
Yeah.
and then even the complaint, the chief complaint of the patient, which is pruritus, lethargy, and lower extremity edema with nausea and emesis.
Okay. You are just reading everything. I'm just talking that one word tell me in this which points towards a renal abnormality, which is very pertinent, related.
Hypertension.
No, listen. See, there is lower extremity edema, right? In your when Doc Polestica would have taught you guys, then she would have taught about edema also. This is very important. See, there is pitting edema, you can say extremity edema, that is like vasocongestion in the extremities. There is nausea and emesis. Emesis, continuously vomiting is happening for the patient, which means that the blood volume is the volume in the body, you can say the water content in the body is less. So the patient is dehydrated. There is vasocongestion in the in the limbs. That's the leg. Now tell me over here. Anyone else can also say. Anisha, you can also continue if no one is saying. What is a very this thing over here, like which points towards an abnormality in the vitals? Hello.
The blood pressure.
Yeah, the blood pressure is quite high, and also you can see this edema and hypertension. Okay, we'll be just moving forward. Wait. See, these are the laboratory findings of the patient. The sodium, the normal range is 136 and 146, but this is sodium is low. The potassium is high. Your chloride content is in the normal range, but your BUN and your creatinine are way higher than the normal one. The pH and all is also fine. That you can find protein in the urinalysis. There is waxy cast and the GFR is 55 ml. Now, according to whatever I said behind, saying if you guys listen properly about the GFR and about the excretion of the cations and the anions, what do you guys think would have been the problem over here? See, what all is filtered out. See, there is lots of creatinine, lots of BUN that's filtered out into your urine. Then your potassium is high, your sodium is low. This basically points towards a renal failure. These things, because these things are very important in your you have to get to know the normal physio of the urinary system in order to know that what this can lead to. This can point towards. So this is the main function, that because of the filtration being the main problem in the system, there is low blood that is reaching to your kidneys, perfusing your kidneys, but there is lots of nutrients that's draining out, and this is a main problem in your chronic renal failure. So such cases would be given to you guys. Chronic renal failure, basically the normal GFR is always 125 ml per minute. This is very important. You guys have to take note of this. But in our case, it was given GFR is 55, which is way less, and your urine output has also to be maintained. Now, in this case, they have not given the urine output, but the urine output is less in this case because it's a renal failure case. And seeing all the things that's happening, like MSS and all, your blood volume is decreased, your GFR and your urine output will also be decreased. Your chronic renal failure, you can say that it's the GFR is less than 60, usually, and it persists for around 3 months or more. If it's less than that, you can say then it's acute kidney failure. Now, talking about the ureters and the bladder and the rest of the system, we talked about the nephrons right now. Now, going on to the ureters. So, the ureters propel the urine from the renal pelvis to the bladder by peristaltic waves conducted along the syncytium of the smooth muscle cells. So, the ureters, they enter the lower posterior portion of the bladder. There is this bladder, then there is the uterovesical junction behind the bladder where the ureters enter. They pass obliquely through its muscular wall and opens into the bladder lumen 1 to 2 centimeter above and lateral to the orifice of the urethra. Sorry. The two urethral orifices connected by a ridge of tissue and the urethral orifice, they form the corners of the triangle, the bladder trigon. They enter it from the posterior, forming the bladder trigon. The lumen of each ureter is lined by transitional epithelium, which is above a submucosal layer of the connective tissue, as well as an inner longitudinal and outer circular layer. For the peristaltic wave, it's very important to have an inner longitudinal so that it passes down, and an outer circular. Outer circular will squeeze, the inner longitudinal will pass the thing in the ureter down where it's important. I don't know why this has happened, but I'm just so there are three poorly defined layers of the smooth muscle. Just excuse me. So there are three poorly defined layers of the smooth muscles that make up the bulk of the bladder. The so-called the detrusor muscle, the lower tip of the trigon, the bladder lumen opens into the posterior urethra, which extends over 2 to 3 centimeters. The urethra, it extends over 2 to 3 centimeters. The wall of the posterior urethra, it contains the smooth muscle cells of the detrusor interspersed with elastic tissue together forming the internal sphincter. So at the top in the ureter, you find that there is a wait, in the ureters, you find that there is transitional epithelium. In the bladder, you find that there is also transitional epithelium, but a bulk of detrusor muscle surrounding it for more peristaltic movements and contractions to expel out the urine. And at the lower side, where it joins the posterior urethra, these detrusor fibers are yet continued along with the elastic tissue, these forming the internal sphincter, uh, which is very important for the voluntary passage of the urine. Now, the internal sphincter is mostly of the smooth muscle cells. The external sphincter is of skeletal muscle cells. The internal sphincter is supplied by the hypogastric nerve fibers and the external by the pudendal nerve supply. The external is under the voluntary control and the internal is under the involuntary control of the autonomic system, and the external is via your somatic system. So this is very important to take note. The sympathetic innervation it arises from the intermediolateral cell column of the 10th thoracic to the second lumbar spinal cord, and the parasympathetic, they arise from the S2 and the S4 segments of the sacral spinal cord. The somatic innervation is also the S2 and the S4 of your bladder. Through the pudendal nerve, these motor neurons innervate and control the voluntary skeletal muscles of your external fibers. I just say bladder, I'm so sorry, external sphincter is S2 and S4 for your somatic innervation, your motor neurons. Now, filling the bladder, it activates the stretch receptors that initiate the maturation reflex. It's very important. It's a spinal reflex arc, and it has its control in the higher CNS system. Now, bladder tone is defined as the relation between the bladder volume and your internal pressure, intervesical pressure. Cortical and the suprapontine centers are very important in the brain, which normally inhibit the maturation reflex, and which the pontine maturation center coordinates. Cortical and the suprapontine centers in the brain, they they contact, they are in connection with the pontine maturation center, and eventually it controls your bladder detrusor muscle and your urinary sphincters. During the storage, there are two phases of your maturation. So during the storage phase, when the water starts accumulating into your bladder, there is stretch receptors in the bladder which send afferent signals to the brain via your pelvic splanchnic nerves. Now, one first senses the urge for voluntary bladder emptying at a volume. When the volume reaches around 150, you will have your first urge to urinate, and then it senses fullness at around 400 to 550 ml. Around 550 or 600, it starts getting into your involuntary, it starts getting out of your voluntary control after your bladder reaches around 550 to 600. Nevertheless, until a socially acceptable opportunity to void itself, like you go to the washroom, efferent impulses from the brain in a learned reflex inhibit the presynaptic parasympathetic neurons in the sacral spinal cord. Now, this statement says that unless and until you want to void yourself, the efferent impulses will actually block your parasympathetic neurons. That is why you don't empty your bladder without your own control, because it's of your parasympathetic neurons in the sacral spinal cord that we studied right now from the S2 to S4 segment, which stimulate your detrusor muscle. Voluntary contraction of the external sphincter probably also contributes to the storage. See, voluntary contraction of the external sphincter, the internal sphincter is under your autonomic nervous system, but the external one is under your somatic nervous system. So it also helps into the storage. Now, the second phase is the voiding phase, which begins with a voluntary relaxation of the external urinary sphincter. It is followed by the internal sphincter. Um, when a small amount of the urine reaches the proximal, that's the posterior urethra, your afferent signal to the cortex that voiding has started basically. The maturation reflex, the maturation reflex now continues as pontine centers no longer inhibit the parasympathetic preganglionic neurons that innervate the detrusor. As a result, the bladder contracts, expelling the urine. So I'll be just revising this whole thing. So your cortical and your suprapontine centers in the brain, they inhibit the maturation reflex via your pontine centers, that is your pontine centers, which controls your bladder, detrusal, and the urinary sphincter. So cortical and your suprapontine centers in the brain are important to remember. They will sense the afferent fibers via your pelvic splanchnic nerves will sense all the stretch that is happening in the bladder when the volume of the urine starts increasing in the bladder. Now, these are usually inhibited uh, as you don't want to expel out without your voluntary control by your presynaptic parasympathetic neurons in the sacral plexus. So this is usually inhibited via these parasympathetic nerve fibers. And then later on, there is the voiding phase that starts when you yourself voluntarily, you will allow your external urinary sphincter to open, This is followed by the internal urinary sphincter, and when a small amount of the urine it reaches the posterior urethra, it senses, and the signals are being sent to the cortex, and your maturation reflex it starts. So the pathophysiology of maturation is very important because there are three major lesions. There is the combined afferent and efferent lesions. There is the afferent lesions separately, and your spinal cord lesions. Now, afferent lesions, what is that known as afferent and efferent lesions? They are, if it continues for a very long time, it also leads to a decentralized bladder, which is that your bladder becomes distended and flaccid, and it can lead to the hypertrophy of the bladder, which actually just discoordinates all your maturation events. Then afferent lesions are the ones when only the sacral dorsal, your sensory fibers are interrupted. Your sensory fibers, that is your reflex contraction of the bladder, which was sensing your stretch receptors, they are being interrupted. And because of that, your stretch receptors won't properly sense your pontine centers, and your reflex will be interrupted, maturation reflex. Now, the spinal cord lesions. Spinal cord lesions happen in paraplegic patients who have paralysis, and because of them, there is something known as your overflow incontinence. Because it's not under your control any how after this, no voluntary control is there. It can also lead to spastic neurogenic bladder. This is very important to remember that the pathophysiology of maturation, your spinal cord lesions can lead to overflow incontinence. There are many kinds of incontinence that you will be studying, but overflow incontinence is because of spinal cord lesions. There is stress incontinence also, but you should not confuse it with overflow incontinence. No. These are important, but I'll be just teaching this after I go on to another one. So, as we studied the GFR and the renal clearance, now the glomerular capillaries, we studied that it's impermeable to the plasma proteins and all the cellular elements, that's macromolecules, it's impermeable. This is just a recap that the GFR is 125 ml per minute, or you can say 180 liters per day. The filtration fraction is GFR upon your renal plasma flow. Then this we all studied that there's fenestrations of the glomerular capillaries, the endothelin and the negative charges, they repel all the plasma proteins. You can say that the filtrability of the solutes, it's always inversely proportional to the size of the solute, and your albumin filtrability is usually approaching zero unless and until there is any nephrotic syndrome or any problems in the kidney, like your chronic renal failure, as you saw, that this albumin is also excreted out. So this is a pathology that was given. This is minimal change nephropathy. Minimal change nephropathy, you can see that these podocytes are being flattened and they have been effaced. That has been detached from the glomerular basement membrane. Also, many more pathologies of the nephrotic. Nephrotic syndrome is basically anything that leaks out. You can just say that in nephrotic syndrome, you can find lipid, you can find protein and everything in the urine. And because of that, all the pathology happens. It can also be in a focal segment, glomerular sclerosis. There can be sclerosis of the glomerulus. Then minimal change disease can also be there. The results are proteinuria and your albuminuria. Now, this is something that is very important. The water that is coming inside the afferent arteriole, it releases it creates your glomerular hydrostatic pressure because it has a tendency to move into the space that has lower concentration. So this is just normal diffusion, you can talk. So this glomerular hydrostatic pressure is 60 mmHg, and the oncotic pressure, whatever proteins and molecules are present over here, will secrete an oncotic pressure, and this will give rise to an inward pressure that's directed. The Bowman's capsule will also have an oncotic pressure that has been released, but and hydrostatic pressure that has been released, but there won't be any oncotic pressure as we assume that there is no protein that's coming out into this. Hello?
I think the slide has not changed. Have you changed it?
Yeah. Where is this slide right now? Can you just tell me?
It's in the PowerPoint 48th slide.
Oh, it's still in the PowerPoint. I'll just wait. Can you see now? Can you see now?
Yes.
Okay. Okay, cool. Did you saw this thing? This?
No.
Kshitij? No?
Yes, yes, we are able to see it.
No, did
Now
you
we are
see
able
it?
to see it.
Oh,
Before we
previously when I
didn't.
was explaining, you didn't see that. Okay.
Yeah.
Okay, no worries. So I
It's
was just
okay.
saying, yeah, I was just saying that these podocytes, they are being effaced. And because of that, it can lead to many pathologies, as I explained, the nephrotic syndrome and so. So I just said about that. And then moving on to this thing I was explaining. So glomerular hydrostatic pressure is an output pressure from your glomerulus because of the water that is coming inside. You can just remember it like anything that's coming inside, it's releasing an hydrostatic pressure outside of that space. And the oncotic pressure, because there is colloid or the molecules inside, like the proteins and all, they are releasing your oncotic pressure, which is an inward pressure because it's directed to maintain inside that space. And then the Bowman's capsule comes into picture, which has we assume that there is no protein that has been filtered out into the Bowman's capsule in a normal circumstance. So the normal oncotic pressure in the Bowman space would be 0, which is an inward pressure to this space, and the hydrostatic pressure will be an outward. So a net pressure, you can say, is always your 60 mg, that is this pressure, minus your both inward pressures, both directed towards this side, that is 32 plus 18, which accounts around 10 mmHg, which is your net filtration pressure, which is important to be remembered. Your glomerular filtration rate is always equal to your glomerular coefficient times your net filtration pressure. Net filtration pressure, we studied that in the normal circumstances, it's 10. So if we want to determine what this coefficient is, your capillary filtration coefficient, then you can say that it's GFR times your net filtration pressure. You cannot calculate your coefficient directly. So in that case, you have to first calculate your GFR and then your net filtration pressure in order to get your capillary filtration coefficient. There are a few formulas that are very important to remember, as we talked about the GFR in the previous one and your capillary filtration coefficient right now. So as over here also one disease is stated that it's chronic hypertension and diabetes mellitus. Now what happens in this is there is loss of capillary function. Because of the loss of capillary function, there is your GFR is decreased, and because your GFR is decreased, there will be less amount of urine and less amount of filtration happening in the blood. So this is directly proportional. As much as the capillary coefficient is there, that much is the GFR. As through the formula also you can see that it's directly proportional. And if there is increased hydrostatic pressure, that the volume of the blood that's coming inside your glomerulus is more, then you can say that it will lead to a net more outward pressure, because there will be a net more outward pressure in relation to the equivalent inward pressure that has not been changed. So it will be mostly it decreases the GFR, but you can say that it's not a primary mean for regulating the GFR, the hydrostatic pressure, as the oncotic pressure is very important. But if there is any stone in the Bowman space, the hydrostatic pressure is important rather than in the glomerulus, because if there is any stone over here in the tract, then the volume that will be, the hydrostatic pressure that will be sent up is always more. And because it's more, it will usually decrease your GFR. This is important in terms of your stones, urinary stones, or any obstruction in the tract, or any genetic formation, any agenesis of the ureter or the system distal to the kidney, then you can find that the increase in hydrostatic pressure of your Bowman space. The filtration fraction shows that it's around 1100 ml per minute, your blood that flows through both the kidneys, because it's around 20% of the cardiac output. Your kidneys are around just 0.5% of your total body weight, but it takes account around 20% of your cardiac output. This is important to remember, that the kidneys, how much blood usually flows via the kidneys is around 1 liters, 1 to 1.2 liters. So I want to say that we are done with the first 2 chapters, this just the introduction part almost, and then in the second class, I'll be explaining about the channels and all. In the starting, I just wanted to say about the pathologies right now. So in this coefficient, the capillary coefficient is reduced. It's directly proportional to the GFR, so it will also be reduced. This is important because it's in the pathologies like diabetes mellitus, your hypertension. As your aging increases, your GFR also decreases. During your urinary obstruction, also your GFR decreases. And also when there is increased plasma proteins, then also your urinary GFR increases. Kshitij?
Yeah, yes, okay.
Yeah, I just wanted to do the first 2 chapters today. So
Okay.
these are just the importance in the first 2 chapters. Rest all is just the base.